Now I would like to invite Dr. Mohammed to introduce our next speaker.
The next speaker, Dr. Angel Mercy, Assistant Professor of Biochemistry, Sri Venkateshwara Medical College Hospital and Research Center, Pondicherry. She has academic experience of 4 years. She was awarded IFCC Task Force Young Scientist Award in the National Conference ACBICon 2016, Mangalore, and she has won various awards and prizes in International Conference ICON 2022 conducted by AVMC Puducherry. She has published research articles in index journals. I kindly invite Dr. Angel. Over to you, ma'am.
Very good morning to everyone. I'm Dr. Angel, Assistant Professor in the Department of Biochemistry from Sri Venkateshwara Medical College. The topic I'll be talking upon today is on harmonization of the clinical chemistry lab. So before I go to the topic as such, I'd like to start with a small scenario. So here is a patient, Mr. Tim, who's gone to visit his doctor for complaints of feeling more hunger than usual over the past few months. He has a history of diabetes in his family, so he went to see his doctor to just have a checkup. For that, his doctor advised him to get a fasting glucose sample tested. So Mr. Tim went home, and the next day he did a fasting glucose test in a lab beside upset. He told him, no, I'd prefer if you do a test in the lab that is attached to my hospital. So finally, he had to be fasting for another day, and he gave a second sample to another test, to another lab. So the next day, when he went back to the doctor, he got two results. The doctor was a bit confused. The first lab gave a result on a plasma glucose of 5.5 millimole per liter, and his lab gave a result of 115 milligram per deciliter. So now the doctor was confused, and he thought, why don't I ask my lab to check it again? And since we already have the sample, he didn't ask anything about the storage conditions or anything. He just asked his laboratory people to compare it with another laboratory. So they also, without any further information, they sent the sample by evening to another laboratory. And on the next day, they got a third result. So it was 88 milligram percentage. So when the doctor saw these three results, basically what he saw was none of the three results were equivalent to each other, and there was a lot of variation between them. So this is a scenario that is quite common in our community. Maybe the third lab is a bit imaginative, but most of the time, doctors usually ask patients to go and get their samples done in a lab that they prefer. So finally, the question that arose was, which lab result is correct? Which is a good lab? So what's the problem? Where did it go wrong? So Dr. Bachman is renowned for her work in method validation and verification. And she stated that the fact that methods are not harmonized is probably one of the most critical problems facing the field of laboratory medicine today. So problem number one, according to her, is that methods are not harmonized. Dr. Greg Miller is renowned for his work with relation to harmonization in laboratory medicine. And he stated that a large number of tests are not standardized, and yet we have clinical guidelines that say if the value is greater than X, then you do this or that. So according to him, problem number two is that we are very sincere in following our clinical guidelines, but we are not yet having proper standardized protocols or procedures. So based on that, I'd like to start the outline of my talk, which is what is harmonization? Why is it needed? What is the scope of harmonization? Harmonization in the phases of the laboratory testing process, harmonization and standardization, the non-identical twins, how to achieve harmonization, what are the barriers towards achieving it, and the global efforts towards harmonization. So to begin with, what is harmonization? Any process that enables the establishment of equivalent reported values. So they are within clinically meaningful limits produced by different measurement procedures for the same measurement. So basically, despite the differences and inconsistencies between labs, we should be able to give mutually compatible, uniform, and reliable results. So what is currently happening is, like in this scenario, a patient has given his blood sample to 3 different laboratories, and he got 3 different results. And in the end, it was difficult to apply a valid clinical guideline and plan on further management. But what should ideally happen is that a sample, even though it's given in any number of different labs, eventually it should be able to it should give equivalent results which are harmonized, so that a valid clinical guideline can be applied, and that will be beneficial to the patient's outcome. So why do we actually need harmonized results? So with relation to the patient, obviously the patient safety. Misinterpretation of results is obviously going to be a risk for the patient. Then we need harmonized results in order to apply and as well as set clinical guidelines for further management of the patient or diseases. Then harmonization also is required to overcome the problems with relation to patients getting access to different laboratories. Patients usually face difficulties like with relation to distance, cost, insurance limitations. But if we have harmonization of results, this problem can be overcome. And then an important goal of our lab, which is having electronic patient records. The patients need not bring their results from day one and carry it around. They should be able to have access to results wherever they go for getting further management. Apart from the patient, we also have organization-related issues like it is required. Harmonization plays an important role with relation to accreditation, which gives importance to trueness and metrological traceability. And then with relation to consolidation projects, it is very beneficial if we have harmonized results. And further, clinical governance. Obviously, our administrators are going to have concerns if patients are not satisfied with the results that they're getting. So based on this, what is the scope of harmonization? Harmonization is not limited to any single part of the laboratory process, but it involves the total testing process. This is basically a brain-to-brain loop. This is basically a brain-to-brain loop, which begins from the physician, and it's called as the pre-analytical phase. When the physician decides on what test has to be given based on a clinical diagnosis that he suspects. Next, the sample, the request is sent to the lab, and then it comes into laboratory process of the pre-analytical, analytical, and the post-analytical phase. Following which it goes to the post-analytical phase, which is again at the point of the physician where he decides on what further action has to be taken. So with relation to the total testing process and to today's topic, I'll be talking mainly on harmonization in our laboratory processes. So to begin with, in the pre-analytical phase, one common thing in the pre-analytical phase is with relation to nomenclature. We use various different terminology across the labs. Like for instance, with relation to vitamin D estimation, the clinician may ask for a vitamin D. Some may consider it as 25-hydroxy vitamin D. Some may use vitamin D2, vitamin D3. So it comes under different names. And some laboratories, they use abbreviations instead of the full name. Creatinine kinase total is given as CK total. So in such relations, terminologies differ from lab to lab. And then the practices of reflex testing. Reflex testing is followed by certain labs and it's not followed by certain labs. And another more common problem with harmonization is with regard to our testing profiles. So if we see some laboratories, they may call renal function test as only urea and creatinine. Some may include electrolytes in that panel. Some may include even uric acid in that panel. So it's going to be varying from lab to lab. And in such a situation, it will be difficult for the physician as well as the patient. Apart from the request, it also has pre-analytical factors also involve the patient's preparation with relation to blood collection, the duration of fasting, the duration of taking a sample after a person has had some drugs. So all those factors also have to be considered, including storage conditions and transport conditions of the sample. So obviously, all pre-analytical factors play a role when it comes to the eventual results, and it can contribute to some amount of uncertainty in the results. Coming to the next phase, which is the analytical phase. So we have learned to time on and again, like pre-analytical, and pre-analytical has the maximum number of, contribute to the maximum number of errors in the laboratory process, and followed by the post-analytical, and the analytical is just around some 7 to 13%. But how much of that analytical errors do we consider to be due to standardization, traceability, or commutability and other factors? So let's see about standardization. Standardization is basically the ability to give equivalent results by metrological traceability to a fit for purpose higher order reference system. Basically meaning that the clinical sample is going to be relevant if I'm using calibrators that are traceable to a higher order reference system. Equivalent does not mean identical. It means that the results are within a total allowable error limit. And this will be consistent with the acceptable risk of harm from a decision based on that lab result. So standardization and harmonization, as I mentioned earlier, the non-identical twins. So standardization, I've already told, it will be traceable to a higher order reference material. What about harmonization? So when you look at harmonization, if you can look at the picture that is there in the bottom. So the first one, the purple stars indicate the patient's results, and these results can be traceable to a reference system, a higher order reference system, and so we consider those results tend to be reliable. Whereas harmonization addresses those tests that can't be calibrated with a or that can't be traceable to a higher order reference material. So thereby its scope is much more. Talking about metrological traceability, it is basically an unbroken chain of calibrations from the clinical sample result to a higher order reference system. So as you can see in the table over here, the type based on the reference measurement procedures and the availability of primary and secondary reference materials, the analytes that can be standardized have been classified into 5 categories. And if you see, the category 4 and 5 are categories which do not have adequate reference measurement procedures or reference measurement materials. To look in deep into the traceability chain, if you see, we are quite familiar with this chain. But as you see, with the increase in traceability, there is some amount of measurement uncertainty that also happens. One of the important things that we have to note when it comes to traceability of our results to a higher order reference material is the secondary reference materials, which should basically be a matrix-based commutable reference material. If the reference material is not commutable, there are chances that our traceability will break. So even though the manufacturer claims that they have traceability, but if it's not commutable, we are not going to get equivalent results across measurement procedures. So what is this commutability? Commutability is basically equivalence of the mathematical relationships between the results of different measurement procedures for a reference material and for representative samples from healthy or diseased individuals. So basically, if we have commutability of our reference materials and our clinical samples, they are going to have a similar relationship when they are analyzed across different measurement procedures. So why does it matter? So we can look at this scatter plot at the bottom, in which you can see that the reference materials are commutable with the clinical samples. And when they're analyzed with 2 different measurement procedures, they have a same relationship. But when the reference material is not commutable with the clinical samples, they do not have a same relationship. And if these non-commutable reference materials are used as calibrators, our clinical samples are also not going to give a similar relationship between 2 different measurement procedures. In such a situation, can it be overcome? Yes. If the bias is constant, a conversion factor can be set up and then we can actually use it. But in such situations, one thing we have to keep in mind is this conversion factor will be specific to the measurement procedure for which it is applied. So now what if we don't have a suitable reference measurement procedure or reference material? So in such situations, we can, the manufacturers usually go about with a harmonization protocol to make the results equivalent from different measurement procedures. This harmonization protocol is usually based on a consensus pool of clinical samples, and they are used to calibrate the further stages of the traceability chain. If you see many, if you can see the picture at the bottom, many analytes are still yet to have, they do not have a standard reference material or a reference measurement procedure. Majority of the analytes go ahead with the harmonization protocol or the harmonization consensus group for a traceability to a reference material. So next, coming to our intra-laboratory comparability. So within a lab, usually large testing laboratories, they may have more than one instrument, right? Even small labs, they may have an additional instrument as a backup instrument. So in such situations, we have to ensure that both of our instruments are giving the same result. We cannot give one result in one instrument. Like one instrument cannot give a result for creatinine as 1.0 mg per deciliter, and our second instrument cannot give a result of 1.8 mg per deciliter. Obviously, it's going to create confusion among the clinicians when such results are being released. So in such situations, we have to do comparability testing between our instruments, which is more commonly known as the inter-instrument comparison. And if we find some amount of difference, it is better to assess the need for adding a conversion factor or if a conversion factor is already set, we have to decide on whether it has to be changed. But just setting up a conversion factor is also not adequate. It has to be periodically reviewed, at least within a 6-month period. So CLSI guidelines are available for conducting such comparability testing between instruments within a laboratory. So another thing is when we have between method differences. So this is from a study by Almond et al. In 2012, where he ran a single patient sample for parathormone in 5 different analyzers. So when he ran the samples, he was able to see that there was a 3 to 4-fold difference between the analyzers with the lowest value of 54 to a highest value of 183. He stated that this could be due to non-commutable reference materials and because the methods are similar, but they do not measure the same quantity, considering the isoforms of the parathormone analyte. So in such situations, method comparison also can be done in our laboratory, where we can assess whether which method is more precise by checking the CV percentage, and we can also see the amount of comparability between the methods by studying the bias as well as the total allowable error. It is preferable not to use 2 different methods while for analyzing a particular analyte, because even though if we set a conversion factor, periodic monitoring has to be done in order to ensure that we are giving adequate or more reliable clinical results. So next, coming to an inter-laboratory comparability, that is based on the scenario that we had seen earlier, 3 labs giving different results. So inter-laboratory comparability is essential so that we can have interchangeability of results or transference of results. There are a multitude of guidelines, but still we are only partially harmonized or unequivocal when it comes to our final results. And this is mainly because we have differences with relation to all phases of our laboratory process, and especially with relation to our analytical phase, we have differences when it comes to instruments, analytical methods, reagents, reagent lots, the calibration, commutability, and traceability. So in such a situation, we can go ahead with the inter-laboratory comparability testing. So this testing can be done by sending blinded samples to a different set of labs and by doing a statistical analysis to see to assess our bias and precision. But more commonly, more standardized way of doing it is by participating in the external quality assurance programs, which is done on a monthly basis, whereby external quality assurance provider is giving us a sample, and we are running the test. We send it back to them and they get the results. So in this case also it's blinded because we don't know who are the other laboratories participating. But this EQUAS is beneficial to us because it helps us to compare the results across the various assay systems, and it also helps us to keep our inter-laboratory comparability in check. The EQUA program and the proficiency testing programs have the additional benefit of not only inter-laboratory comparability, but it helps us also to monitor the success of any harmonization or standardization protocols that we implement in our lab. In addition to the external quality assurance programs, setting up of quality indicators at different levels of the analytical process will be even more beneficial with relation to harmonization of our laboratories. So finally, in the analytical phase, there are basically 6 pillars that hold up the harmonization, and 3 of them were given by the Joint Committee of Traceability for Laboratory Medicine. That is availability of certified reference materials, reference methods, and reference measurement laboratories. Beyond this, the reference measurement laboratories came up with 3 more pillars where they suggested the need of universal reference intervals and decision limits, accuracy-based external quality assurance, and harnessed terminology and units across the labs. So coming to the post-analytical phase, in which the last 2 pillars actually fitted into, the post-analytical phase also includes nomenclature or the terminology as mentioned in the pre-analytical phase. So a doctor, if he asks for one test, we cannot give a test report with another name. So it's better to have a harmonization between the pre-analytical as well as the post-analytical terminologies that we use. And in addition to the terminologies, the reporting units and the format. As you had seen in the scenario, all 3 labs, they had given different reporting units. In fact, the first lab and the third lab, which had milligram per deciliter, still one lab reported it as milligram per deciliter, the other one reported as mg percentage. So we should be uniform in our reporting units, because that also can cause confusion to the physician. So most of the time, physicians and patients, they consider our results comparable based on the numerical value alone. There are many chances in which units are usually overlooked. So we actually play a role in overcoming that by ensuring that we have harmonization among our terminologies and among our reporting units. Another thing in the post-analytical phase, which is very important, is which comes with relation to the reference intervals, decision limits, and the critical values. So as mentioned earlier, the units and the numerical values of the measurements play an important part with reference intervals. As you can see in the table that is displayed on the side, harmonization has been suggested by many international organizations to be given under the SI units, but the problem is when it comes to standardization or lack of traceability to the SI units. In such situations, reporting results with the SI units are difficult. So most of our labs usually go ahead with the conventional units, but even within this conventional units, there is a lot of variation among the labs. So manufacturers usually include the reference intervals with their products, but they suggest that we adopt our own, and based on the CLSI guidelines, as mentioned in the first presentation, there are guidelines available on how to derive a reference interval of a particular population using a minimum of 120 samples, and deriving such reference intervals in a population may be beneficial, maybe more beneficial if it's evidence-based or more clinically based. So when reference intervals in a cross-section of labs show variability, it will obviously result in misinterpretation of results. As you can see in the graph that is on the right side, this graph shows the reference interval along with the reference intervals of the results in a healthy population along with that in the sick population and the decision limit that was decided. So if another lab is going to have a different reference interval, what happens is the decision limit that if it is still implemented on the changed reference interval, it is going to cause the unnecessary treatment of people who are actually healthy or people who do not require treatment. So care has to be taken that when the reference intervals are changed, decision limits also have to be monitored, and similarly our critical value results also have to be kept in monitoring. So finally, how to achieve comparable results? So with relation to the analytical phase, mainly harmonization of standard procedures involving all phases of the testing process is required in order to achieve comparable results. In the analytical phase, calibration of all procedures traceable to a common reference system is needed. Then all measurement procedures should measure the same quantity. There are molecular differences for different analytes. So in such situations, it is essential for us to go beyond and know whether our measurement procedures are checking or measuring the same quantity, especially with relation to the composition. So, and last, it's not enough if we just implement all harmonization strategies. Surveillance to monitor and maintain consistent performance is the most important part, especially by our proficiency testing and quality indicators. So now finally, at the end of this, a lot of information has been given, but the main question arises as to who is responsible for this? Am I supposed to do this for my lab, or will the government do it? Or who is going to come and do all this? So let's just look into it. When it comes to laboratory protocols, the test requesting, the sample handling and reporting comes under the part of the local laboratories, where they should work together to ensure that there is harmonization among these. The next thing is with relation to clinical reports, the test names, the units, the reference intervals, and the decision limits. Therein comes the role of the local laboratories along with the joint efforts of the national organizations involved with laboratory medicine. And finally, the international organizations play a more important role when it comes to our technology and the information systems, the traceability and commutability of our measurement procedures and materials, and the clinical guidelines. But if you see in the end, it is all three levels, the local, national, and the international levels have to work hand in hand in order to make sure that harmonization is available throughout the testing process. So why haven't we achieved it yet? What are the barriers? As mentioned earlier, there is a lack of appropriate reference measurement procedures or certified reference material, and it is still ongoing in process for harmonization and standardization of several analytes. There is inadequate definition and specificity of the tested substances. And there is a lack of universally accepted protocols and oversight for information. Every lab will be happy to follow guidelines and instructions of a protocol, but this is lacking when it comes to harmonization. Different labs are giving different approaches towards harmonization. So as of now, a universally accepted protocol is not yet set in, but it is still in the process. And finally, a common factor which hinders many of the improvement processes is inadequate funding and other resources. So coming to the global efforts, we have many ISO guidelines which help us to go about harmonization. The International Consortium for Harmonization of Clinical Laboratory Results, that is the ICHCLR, works to coordinate the harmonization activities throughout the world. They do gap analysis to find out where we are missing out, in which steps are we missing out, and why are we lacking in this harmonization process. And this team is mainly mainly involves international organizations like American Association of Clinical Chemistry, the IFCC, ILAC, and FDA in vitro devices manufacturers. So as you can see in the small diagram below, we're trying picking up the low hanging fruit is what is happening. We do have analytes that are within the standardization and the harmonization process, but at the same time, we do have many routine analytes that are still not having harmonized processes, especially with lack of reference measurement procedures. So with that, the take-home message from my presentation is harmonization in our laboratory involves setting up of following the ISO guidelines, the CLSI guidelines, and having harmonized standard operating procedures at all phases. In the analytical phase, standardization, traceability, and commutability play a very important role for harmonization. And inter and intra-lab comparability is the responsibility for each laboratory, and monitoring it by doing external quality assurance and proficiency testing participation, as well as monitoring our quality indicators and taking up corrective actions based on our performance. And finally, terminology, the reference intervals, and decision limits. All these aspects, they contribute to the various phases of the lab in order for us to give right results in the right form. But only with our analytical phase, it's not going to work out. The pre-analytical phase is also required. That is a right test choice at the right time on the right patient, as well as the post-analytical phase, the post-analytical phase also plays a role. So with this, I'd like to end my presentation. I'd like to thank Dr. Ramesh sir, Dr. Sharbi madam, head of the department, and the organizing committee for giving me this opportunity to present this topic in the CME. Thank you.